My name is Jeff Hart Cooper, and I'm a primary care pediatrician through Stanford Children's Health. I actually have offices in San Mateo, Menlo Park. And I'm here with Carrie Chan, who's another one of our providers. And we just wanted to welcome everybody to this kind of webinar PowerPoint today. We're super excited to share more about PrEP with you guys, and then also introduce everybody to our virtual PrEP program, which we launched a few months ago, and now we're actually accepting patients from really anywhere within California. So we're very excited to share about that. There was a similar presentation that we had a few months ago, and so some of it will overlap, but we'll get started. Just so that you know, if you guys have any kind of questions along the way, feel free to share those in the Q&A box, and we'll get those at the end of the presentation. So what are we going to talk about today? We're going to go over the epidemiology of HIV in youth. We're going to introduce you all to PrEP, or pre-exposure prophylaxis for HIV. And then we're going to walk through which kind of patients might benefit from PrEP, as well as give you guys a primer about how to prescribe and monitor PrEP yourselves, and then introduce you to our virtual PrEP clinic if you do have any patients who might prefer to have an entirely virtual PrEP kind of care team, or for those patients that you might find a little bit trickier. We're happy to work with them as well. So we're going to start out by just talking about the basic epidemiology. The takeaway message is that many new HIV diagnoses are among youth. And so this is looking at national data here on the right. This is the number of diagnoses of HIV in the United States in 2017. And what you'll see is about 20%, or 1 in 5, of all the HIV diagnoses in these different age groups is occurring in patients 24 and younger. And so that's a really significant and often surprising number for pediatric providers. And we know that, people phase patients out of their practice anywhere from, 18 to 21 usually. And so the other takeaway message about this graph is really the fact that these, 21 to 29-year-olds who are a big chunk of these HIV diagnoses. And when we think of these patients, a lot of them maybe haven't successfully transitioned from a pediatric to an adult provider. And so really our sexual health messaging and the conversations that we have with these patients is really important until they can transition to an adult provider. So even if you may not see a patient who's eligible for PrEP today, these conversations that you have with patients and even bringing it up can really have long-term impact in terms of their health. When we look at our local counties, our data pretty much match the national data with the exception of San Mateo. This looks at new HIV diagnoses in patients younger than 30, and so they just didn't have granular enough data for the 24 and younger. But we see that nationally about 40% of these patients, or 40% of the infections are among patients younger than 30, and that's similar in Alameda and Santa Clara counties. When we think of a young MSM, or a young man or a man who has sex with other men, they have a 1 in 6 lifetime risk of acquiring HIV. So that's about 16%. That's a really significant risk over the course of their lives. And so this is something that's really front and center. And this is something that creates a lot of anxiety that really, influences, sexual partners as well as just general health and well-being. And we compare this to other groups who are at risk of HIV, such as women and men who inject drugs. We see the numbers are vastly different. And then compared to heterosexual men and women, obviously dramatically different as well. Now, when we look a little bit closer, beyond this 1 in 6 risk for MSM, we see that there's really significant racial and ethnic disparities in lifetime HIV risk. And so when we look at the graph at the bottom, we can see that African-American MSM have as high as a 1 in 2 or 50% lifetime risk of acquiring HIV. For Hispanic MSM, it's 1 in 4 or 25%. And so this is a takeaway message saying that despite all the advances that we've had in terms of increased HIV screening, increased rollout of treatment and viral suppression to reduce community viral load, and increased talking about safer sex and condoms, there still is a really significant gap that we can fill, and PrEP really provides an opportunity to help narrow this. All right, so let's talk about PrEP. So PrEP is a daily pill to prevent HIV. Just like an oral contraceptive pill can prevent pregnancy, PrEP is kind of a similar and parallel process. There's two medications that are FDA approved. And to take one step back, both of these medications have been used successfully for treating HIV for years and years and years, including treating children with HIV. And so there's a long track record of safety. Truvada was FDA approved for HIV prevention in 2012. And up until 2018, Truvada was just used off-label for adolescents, so patients younger than 18. But fortunately, in 2018, it also became FDA approved for HIV prevention in young people as well. Descovy is another option. We're not going to get into the details too much in terms of picking between the two. I would say in otherwise healthy young people, Truvada is almost always completely fine and perfect. In the rare case that you have a really significant concern about bone mineral density or significant renal disease, then Descovy might be a good option. And Truvada will be becoming generic pretty soon. And so that's another kind of from a cost perspective. It's helpful to think of that as well in terms of Truvada. PrEP has a USPSTF grade A recommendation for HIV prevention. And when it's taken daily, there's a greater than 99% risk reduction in sexually acquiring HIV. And so really, really significant ability to reduce that lifetime HIV risk for patients. As I mentioned before, we're using this in combination with safer sex practice, exactly like the counseling we've done in terms of pregnancy for years and years and years. And then this final point is really the basis for why we've started this virtual PrEP program and why we're trying to get the word out about PrEP is that in California, patients aged 13 to 24 years have the greatest unmet PrEP need compared to any other age group. And so this is just a metric that looks at the number of patients that are on PrEP versus HIV diagnoses in each age group. And there's really is potential for us to expand access to these patients, and you as pediatric providers are really the key in making that happen. So unfortunately, how we saw the significant racial and ethnic disparities in HIV lifetime risk, we also see that in PrEP use. And so this was a survey that was done by the National HIV Behavioral Surveillance Group in 2017. And what this did was it asked patients about PrEP awareness, whether they discussed PrEP with their provider in the last year, and whether they've used PrEP in the last year. And what we see in these columns, in red, that's white MSM, in orange, that's Hispanic MSM, and green is Black MSM. And we see significantly lower rates of PrEP awareness, but then also lower rates of discussing this with the provider. And so this is something where we can really be cognizant that these disparities exist and really make an effort to make sure that we're talking about PrEP and HIV prevention with absolutely every patient to try to counteract some of these access issues that we're seeing. And when we look at PrEP availability within the state, our program as the virtual PrEP program is really seeking to help reduce these disparities as well. So now we're going to go through the clinical process of screening patients for PrEP and then prescribing PrEP. So who benefits from PrEP? I would say that in a big picture view, any patient that you think might be at a heightened risk for acquiring HIV, you want to think about PrEP for. More specifically, if you wanted to think about specific kind of risk behaviors and whatnot, we think of any patient who is not always using condoms during sex, and they're not confident that their partners are HIV negative. And so this is always, kind of tricky. As we know, like patients don't always tell us the truth about everything. But if somebody's having multiple sexual partners, a lot of that disclosure can be just verbally, like, are you negative, yes or no? And that patient may not know a lot about how their partner thinks that they're HIV negative. For example, like when were they tested? What partners have they seen since then? There's a lot of nuance to that really being 100% confident that somebody's partner is HIV negative is a hard thing to do, especially when you're having multiple partners and you're not in kind of like a communicative, monogamous, more long-term relationship. The second piece to think about is if they've recently had a sexually transmitted infection. And this is for a few reasons. I think, most obviously, it's demonstrates that they're not using protection if they did acquire an STI. And the second factor is that having an STI can actually increase the transmissibility of HIV by causing a lot of local inflammation. And so two patients who have the same sex with the same person, if somebody has rectal gonorrhea, there's an increased likelihood of transmitting HIV. And then the third piece is that if you have any patients who are exchanging sex for money, housing, or drugs, PrEP could be a good option just because of the limited information that they would have about their sexual partners. Those patients who are injecting drugs and sharing needles. And then finally, any patient who's worried about getting HIV for other reasons. And for me, this really means that if a patient's always anxious about getting HIV, if they're asking a lot of questions about HIV, maybe they're doing certain sexual behaviors, they're having certain partners that they're not disclosing. And so always to keep an ear out and pay attention to what your patient's telling you, even if they're not coming out and telling you that they're having multiple sexual partners. Just kind of reading between the lines there. And then the last part that I would say is that, if you have a patient, for example, this is, it's August, let's say that, our patients are going to college, if, college is in session, which is a, much bigger topic these days. But even if they haven't had, sex with other partners so far, if they're going to college, this would be a conversation you really want to have with them because they would have an anticipated risk in the near future. So not only thinking about what's happened in the past, but really thinking, until the next time this patient sees a provider, like, are they at risk of acquiring HIV? So to walk through this, we're going to go through a case. We have our patient, Jimmy C. He is an 18-year-old who's here for a well teen check. And we're going to ask Jimmy about his sexual health. There's a lot of different ways that I'm sure everyone asks about sexual health. When it comes to asking about specific questions that would help us to understand Jimmy's kind of PrEP eligibility, we can think of the mnemonic PrEP. And so that talks about partners, whether he's having receptive or insertive sex. Has Jimmy ever had an STD before? And then how often is Jimmy using protection, and has he heard of PrEP? So Jimmy tells us that he's had 5 male partners in the last 6 months. He tells us that he bottoms and tops. And so this is commonly referred to as bottom is receptive and topping is insertive sex. And so he's having both. And when we think of HIV transmission risk, we do know that bottom or receptive sex is a higher risk activity. And so if somebody's having unprotected sex in general, we think about PrEP, but certainly certain sexual behaviors are more likely to transmit HIV than others. Has he ever had an STD? He doesn't think he has. Another teaching point with this is that we really do want to think about checking for STIs or STDs at every site of sexual exposure. And so if somebody's having receptive oral sex, we should be swabbing the pharynx for gonorrhea and chlamydia. If they have any receptive anal sex, we should also be swabbing the rectum. And what we see often is that patients are only peeing in a cup and they're using that as their STI-free screen. But we should always think about swabbing all 3 sites. And then we asked Jimmy about protection. So he uses condoms some of the time, and he has heard of PrEP. And so given this information, we want to think, what is Jimmy's HIV risk, and should we offer him PrEP? And when we look back on our list, we see that Jimmy, he's not always using condoms during sex, and he's not confident that his partners are HIV negative. And so Jimmy would be an excellent patient to discuss PrEP with. Now we're going to go through the details about how to actually start PrEP. So the first thing you want to do when we're looking at these 4 kind of bubbles below here is you want to rule out post-exposure or PEP eligibility, and you want to rule out current HIV infection. So for post-exposure prophylaxis, you think of any patient who's had a potential HIV exposure in the last 72 hours. Because if that's the case, PrEP is not the best tool that we can use to prevent that. We really want to presumptively treat as if they'd acquired HIV for a month with a 3-drug regimen instead of the 2-drug regimen of PrEP. This is really important, and this is something that we've seen over and over again, is that it's very easy to think about just starting PrEP, but we always want to say, hey, has the patient been taking PrEP recently? Have they been exposed to HIV if they haven't been? Because that's a totally different path than just starting them on PrEP. The second part in terms of ruling out HIV infection. So when we think of the best tool that we have to rule that out, we just have to go back and remember the different window periods for certain tests. And so if a patient has had unprotected sex in the last 30 days or has had like viral-like symptoms in the last 30 days that would be considering for acute HIV, those are fever, sore throat, rash, lymphadenopathy, kind of flu-like, usually with less of the cough piece. We really want to think about sending an RNA or viral load because they may not have had the antibody response yet. So recent sexual exposure, potential recent viral illness, always be thinking about sending this RNA or viral load because we may not have the antibody response yet. If they haven't been recently sexually active, if they haven't had any recent viral symptoms, then a fourth generation antigen antibody test is a good option. And then finally, there are just antibody tests, and those have the longest window period. And so some can be as long as 3 months. I think that was kind of the classic teaching. A lot of those have to do with like the Aura Quick test. And so I would just be aware of the tests that you have and understanding what they're testing for, and just remembering that RNA viral load is going to be the most kind of recent and specific. The antigen brings in another level of specificity that makes it a little bit more recent. And then the antibody is the longest window period. All right, so then we want to think about labs. And so here we've broken this down to our first visit, then our labs that we're getting every 3 months, and then our labs that we're getting every 12 months. So for the first visit, you want to have an HIV test, and we just discussed the different tests that you might want to consider ordering. You want to do STD testing, and so you want to check gonorrhea and chlamydia at any site of sexual exposure. I will almost always do 3 sites, and so just think of a urine as well as a rectal and a pharyngeal swab. And then you also want to be checking a serum RPR to screen for syphilis. Because of Truvada and the tenofovir component, we do want to monitor creatinine to just look at kidney function. I would say it's exceedingly rare that you uncover any patient with any kind of, acute renal failure or any kind of renal issues on this initial screen, but that's why we're doing it. And then it's also extremely rare in otherwise healthy young people that we see any creatinine bump that's significant over time. And so to kind of reassure everybody that this is an extremely safe medication, but that's just something that we want to keep monitoring. We also do a hepatitis B panel as well as a hepatitis C panel to make sure that there's not any current hepatitis B infection that would be partially treated by starting PrEP and then potentially flaring if they were to come off. And then Hep C is just a part of our routine STI screening. Every 3 months, we're going to repeat the HIV testing. We're going to repeat the STD testing as well as the creatinine, but we don't need to repeat the Hep B panel because we've already done that once just to make sure that they're immune or to make sure that they're not currently infected. And one thing that you'll notice comes up a lot is when you're doing these panels is that a lot of patients have this waning Hep B immunity that, as pediatricians, we're not routinely checking for. And so if you do notice that their antibodies are low, then you would obviously want to revaccinate them. And then every 12 months, we can do hepatitis C testing. The next part to really talk about is the adherence plan. And we're going to go into a few slides after this. But PrEP only works if you take it regularly. And so really having a great conversation and coming up with ideas about how to help this young person take pills on a regular basis is super, super, super important. I'm sure everyone has a lot of different ways that they do this already. Some ways that I found helpful are there's certain apps. So Round Health has an app that will actually chime at a certain time every day and just remind the patient to take their medicine. They don't have to list what the medication is. They can just have a general reminder there. You have phone alarms. There's certain text messaging services that are helpful. And then, if it's safe to have PrEP out, just having it in a place that's really convenient. So next to their toothbrush, hopefully they're brushing their teeth at least once a day, next to the bathroom mirror, but obviously this would depend on, if they're at home and whether their parents know, that kind of thing. We're gonna go through a few slides to touch on adherence because it's a really important piece in terms of PrEP effectiveness. Our takeaway message, like most things in medicine, right? Greater adherence gives you greater protection. This is a graph that looks at HIV incidence on the y-axis and then concentration of PrEP, or in this case, Truvada, in the blood on the x-axis. And what you see is that as blood concentration goes higher, HIV incidence decreases. And it's pretty dramatic in terms of getting to that 4 to 6 tablets a week. So ideally, we're saying you should be taking this 7 days a week. But really noticing that, like, if they're not taking it, they're obviously not going to have any protection from it. And there's always the potential that if they think they're protected, would they increase their potential risk behavior? And that's something to think about. But overall, it's just very important that you keep the daily medicine going. And there's a bunch of tools that we have through our program and some other ones that I'll share with you in a few seconds. This specifically looks at youth adherence. And what you'll see here, this is a trial that was done among 15 to 17-year-old men who have sex with men in 6 cities as a part of the Adolescent Medicine Trials Network. It was ATN 113. Of the patients that were enrolled in this trial, they had dried blood spots, looking at blood levels and then correlating those blood levels with adherence, and then obviously making sure that the blood levels were high enough that they felt like there was protection. And so we see these different quadrants. Over here, this was actually put in wrong in the paper, but if the blood concentration was greater than 700, they assumed that there was enough protection there, that they would assume that the patients were taking this pill on a regular basis enough to be protected from HIV. And so what we see here are these different time periods when they did the blood spots, 4 weeks, 8 weeks, 12 weeks, and then they spaced out every 12 weeks to 24, 36, 48. In the very beginning, only 54% of young people had protective drug levels. And so this is a huge opportunity to make sure that patients are taking their medication on a regular basis. And it's also, you can kind of look at this with a glass half full or glass half empty. I mean, compared to nothing, this is obviously better, but there's a lot of room in terms of further adherence support that we need to keep in mind. The second part of this slide to just bring up is that when you spaced out visits, or when they spaced out visits in this trial, adherence also drops. You went from about 50% to about 20 to 30%. And so this really highlights the fact that we should be doing more frequent follow-ups with young people, especially, and then maybe spreading that out with time, but just think that these more frequent contacts are more important, especially for young people that you might be working with. So in addition to that, there's actually been some promising data looking at different ways to improve adherence in young people. And so this was an RCT, the EPIC RCT that was done in Chicago between 2015 and 2016 that provided 9 months of free PrEP. And it compared either PrEPmate as an intervention here versus standard of care, which is just general counseling. PrEPmate was this digital health solution that provided the option of daily pill reminders and then weekly emails and other kind of information on their website. But what we saw in this trial was that the arm that had PrEPmate actually had really significantly improved adherence compared to standard of care, and that we did not see any difference based on age, race, ethnicity, education, or insurance. And so this is also the basis for our goal of adherence support through virtual PrEP. And this is just a reminder to you as providers that, like, the more that you can stay connected with your patients, we think that the easier it will be for patients to adhere. This second slide also looks at component of PrEPmate, and it asks patients, were these components helpful or not helpful at all? And what you see here is that these daily pill reminders and weekly check-in messages were really helpful for patients in terms of maintaining their adherence. And so these are 2 specific strategies that you can try to implement, not only with PrEP, but just general adherence in general. And then finally, you've gone through all these 3 pieces. You want to think about your follow-up plan. I usually like to chat with the patient in a week or 2 to make sure that they've gotten their labs, to see if they've picked up their medication, and then to go over everything, because it can be quite the download during that first initial visit. I would recommend starting with monthly visits and then spacing these out as adherence concerns decrease. You can have them come into the office, you can do it virtually, you can call them. But at least touching base. You'd be surprised at how many people will just stop taking their medicines and you don't know about it. And there's very common things that you can help them troubleshoot. And the third piece that's really, really important is you want to determine what insurance coverage you're going to use. And this is going to be really driven by confidentiality needs for patients. We're going to talk about that in this next slide. So if the patient doesn't have any confidentiality concerns, meaning that they don't really care if their parents or guardians,
or like a seminar.
Oops, sorry. If they don't have any kind of insurance issues, then you can just use their standard insurance. It's almost always covered. There's copay assistance programs that can help with costs. If there's confidentiality concerns, it gets a little bit tricky. So our family packed patients, the visits will be covered. The STI screening will be covered. The creatinine won't. But for these patients, we need to find another way to pay for PrEP. And so if this is a patient that's like, I don't really care if my parents find out, but I don't really want to tell them, what you can do is you can block disclosure of that information by listing on myhealthmyinfo.org. But the reality is that any parents or guardians are going to see, their deductible kind of dwindle away, and that they're going to start asking questions most of the time. And so you need to talk through that with your patients. Your other option is to enroll them in Medi-Cal minor consent, but this requires an in-person visit to register. This is pretty cumbersome. It can be challenging, but for really motivated patients, it's an option. Or if you already enroll patients in your clinic, that makes it even easier. And I'm not sure how this has really changed with shelter-in-place orders. This hasn't come up for us recently, but I would assume that they're making it a little bit easier now, or at least I would hope. And if your patient is very sensitive about confidentiality needs, you always have the option to refer them to Planned Parenthood, and that way everything would be totally covered through a combination of family pack and then private funding as well. And then finally, you can always call us or email us if you have any specific questions, and we also, accept referrals if you want us to help tease that out a little bit more. In terms of the side effects to look out for, about 1 in 10 patients will have some GI discomfort. We call it the startup syndrome. And so this is nausea, gas, and bloating that resolves by about 1 month. So it's good to talk to patients about that when they're starting, and hopefully you'll be able to catch this at the 2-week follow-up and then the 1-month follow-up. Any kind of renal side effects are really rare. So it happens in about 1 in 200 adults, so much less common in otherwise young, healthy people. This is reversible if you discontinue PrEP. And so again, it's a pretty rare thing to find. And also remembering that Descovy is potentially another option that you might have. And then the third thing that comes up is this question of bone mineral density loss. And so they have seen that there's been about a 1% decrease in bone mineral density when patients are on PrEP. This is transient and it comes back right after they come off. This is similar to Depo. And we don't see any increased fracture risk. And so that's really significant, is that you're not putting them at a higher risk for fracture, because we know that bone mineral density measurements overall are, they're associated with fracture risk, but it's an incomplete predictor of it. And another thing to keep in mind is, HIV infection itself also decreases bone mineral density. And so this is a conversation you can have with your patients, but certainly I think that the benefits of PrEP really outweigh any potential risks given this transient effect in bone mineral density. All right, now we're going to return to our patient, Jimmy. So you started him on PrEP. He's back 4 months later. He tells you that he was taking PrEP daily, but his prescription ran out last month. And he wants to continue PrEP and requests a new prescription. When you're talking to him about his sexual health, he does report that he had condomless anal sex about 2 nights ago. So the question is, should we just go ahead and restart him on PrEP? So if we go back to our list, we always start with ruling out PEP eligibility and HIV infection. And so Jimmy has not been adherent to PrEP regularly. And so we have to think of him as starting from the beginning. He also is telling us that he had unprotected sex 2 nights ago. And so you really want to think about post-exposure prophylaxis for him. If this comes up, there's a really helpful 1-800 PEP consultation service. I know that institutions also have their own as well, but here's the number here. And it's an almost 24-hour hotline that you can call to help tease this out, because we know that you want to start PEP sooner than later. No later than 72 hours, but certainly you want to start it as soon as you can after the exposure or potential exposure. Final point, what if your patient has a positive HIV test while on PrEP? You want to stop PrEP, and then link them to HIV care. Hopefully this doesn't happen, but you know, by treating it with 2 ARVs instead of 3, we're only partially treating it, and so you would just want to stop PrEP while you're linking them to HIV care. All right, so finally, we're just gonna give you guys a little bit of an overview of our virtual PrEP clinic for adolescents and young adults at Stanford. So this is the only youth-focused program in the state of California. And again, we launched to any patient within California about a month or 2 ago. And our goal is really simple. So we just want to make it easier for adolescents and young adults to access PrEP in California. And we do this through a variety of ways. To give you a basic overview, patients have free, secure, and confidential virtual visits from the patient's preferred location. And this is something that now with COVID, we've all adapted our practices in certain ways. And so we've had this whole virtual and digital health kind of revolution that way. And this is in line with that. Patients will be given a PrEP doc, just like any other subspecialty, where they can build a relationship with that PrEP doc over time. And all of our docs are Stanford pediatricians or adolescent medicine providers. And the takeaway message too with this program that I think really differentiates it from others is that as pediatric providers, we know that it's more than just prescribing PrEP, and we're really talking about overall sexual and social health. And this is different from other kind of more commercial platforms that are a little bit more about kind of just dispensing PrEP and labs. And we know that there's a more holistic approach that we have to take with young people. So a few pieces that we have, like a few features of our program. We talked about the importance of establishing a relationship with their PrEP doc to really build continuity and trust and to be able to make more of an impact in young people's lives as opposed to just kind of handing out PrEP. Because we do this all virtually, we have patients just send in their labs by either self-collecting if it's a pharyngeal or rectal sample, or just by going into the lab to have their blood and urine drawn. For self-collection for the pharyngeal and rectal samples, a lot of labs don't actually carry these swabs. And so we actually mail them to either the lab or the patient's address, depending on what their confidentiality needs are. And we also have self-collection instructions, which we've included on our website, which you're welcome to use. And then our adherence plan is also a really robust and exciting piece of our program. And so kind of just through our EHR, through Epic, we're able to send secure messaging reminders on a regular basis. We also have a multidisciplinary adherence support team. And so we're going to be expanding physician reach by working with a variety of other people. Specifically, we're looking at groups of medical students that are going to be supporting us as well, just to allow those more frequent patient contacts. And this is going to lead, we hope, to an improved retention and care, as we've seen in studies over and over again. And then finally, having this all virtually really provides patient-centered follow-ups. And so we're able to, eliminate transportation barriers, provide geographic flexibility within California. So, a bunch of my patients now, like I'll see them in my office in San Mateo, they go to, UC Davis, UCLA, we're able to make that continuity, reduce time missed from school and jobs. And then with confidentiality, I think the other thing that's really exciting about PrEP and virtual PrEP is the fact that parents, if they're coming to these visits with their children, there's not that awkward kind of waiting to have the conversation and, what did you talk about with the doctor, that kind of thing. And so virtual care has a lot of potential for adolescent and young adult confidentiality. Here is some referral information. I think this was also included in the PDF that was sent to you guys. But if you're interested in referring a patient, you can just go into MD Portal. You can also call these numbers or fax the referral to us. We just ask that you include the patient's confidential phone and email so that we can contact them directly. And patients are also welcome to just directly call us. They don't need a referral. And they'll just be linked with our schedulers, and then we will start their scheduling for their first appointment. All right, so our take-home messages today. Teens and young adults can take PrEP to prevent HIV, and we're absolutely here to help and support you in doing that. Before you start PrEP, always remembering to assess for post-exposure prophylaxis eligibility, as well as acute HIV infection. You want to agree on a daily reminder to help promote adherence and really to have good follow-up in place. I recommend starting with monthly follow-up at first, and then you can always space this out with time, but we know that retention is really tied to follow-up frequency. And then to really anticipate confidentiality and cost issues and balancing that in terms of insurance coverage and paying for the medication. If you guys have any future questions, you're always welcome to email us, just prepadmin@stanfordchildrens.org. We also have a form on our website as well. And there's our website below, just prep.stanfordchildrens.org. So thanks for your time. We'll take any questions that anybody has. And again, feel free to reach out to us if you have anything else on your mind that we can help with. Thank you.
Thanks so much, Dr. Hart-Cooper. So go ahead and you can type in your questions in the Q&A on the right-hand side. You can also virtually raise your hand. I see that Jasmine has her hand raised. So Jasmine, I'm going to go ahead and unmute you so you can ask your question.
Sorry about that. I think I raised my hand inadvertently.
No problem.
Sorry about that.
And Katie said, outstanding overview and review since it was murky from the time I initially saw it. Thank you, Jeff.
Thank you, Katie. I guess the other thing that I would add, I think there's a few PCHA and Stanford docs on this. You may have noticed that when you order an HIV test, that's now been changed to prompt you to think about if this patient's eligible for PrEP or not. And so you also have the opportunity to get linked to these smart sets that we've tried to make, ordering all the necessary labs as easy as possible. You can also receive a link to receive the same training that we just went over by clicking the second option, which is to link it to your in-basket. And that's something that will pop up in your in-basket and you can access it whenever you want. It's also listed on our website. And then the third option is you can also place the referral from that as well. So that may be something that you may have noticed.
And then Artie had the question, is this clinic free for patients?
Yes. So what we do is we set up patients with Family Pact and we have our first visit together and that's all covered. And then from there, we have to tease out their confidentiality needs to figure out how to pay for PrEP. Because again, Family Pact does not pay for PrEP. There's a lot of other options that we have. And that can vary from, billing their insurance, their private insurance and continuing that through that versus, if they have Medi-Cal, it's usually a little bit easier versus navigating these different ways for them to access PrEP. So 100% free for the first visit. And then from there, we can continue to do these as free Family Pack visits, but we just have to figure out the medication piece.
He said, thank you. And then Toby asked, can you clarify about the swabs that you need?
Great question. So you want to use the Optima swabs, APTIMA. And these, they kind of look like strep swabs, but you would just do a swab in the back of the throat and then a swab in the rectum. If you go to our website, there's self-collection guides, which can also be helpful for clinicians. And when you send these off, it's just sending off the usual kind of gonorrhea, chlamydia, NAT test, and your labs will be able to run them. The trickiest part is collecting these. So if you are going to send them to patients, or if you want your patients to self-collect, you actually need to send them the swabs because the labs don't usually stock them. And so I usually just stick them in like a manila envelope that's pretty generic, and I'll usually send it to their house if they're okay with that. But you can definitely collect these in clinic. It's very easy to do as well. And again, the swabs, they're the Optima, APTIMA swabs.
And Toby said, thank you. And we have no other questions for now. We'll give everybody just a few more seconds in case they want to type it in. Going once, going twice.
All right. Well, thank you everyone for your great questions and thanks for participating. And again, these are our email addresses. That's our website, and feel free to ask us any questions that come up. You can also send me within Stanford, feel free to send us just epic messages as well if you have specific ones about your patients. So always happy to help, and don't feel shy about reaching out.